Hi, everyone. Thank you for joining our Citywide Grand Rounds. It's a special lecture because it's also the Mary Seeman lecture. And we've got people coming in from the Future Psychotherapy Conference as well. So thank you for joining us for the Citywide Psychiatry Grand Rounds. Before I begin, I just want to say a quick land acknowledgement. We want to recognize many Indigenous nations that have long-standing relationships with the territories upon which the sites of the Department of Psychiatry is located and precede the establishment of the University of Toronto. We acknowledge the presence of our traditional treaties of many Indigenous nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee and Wendat people. Today, this land is home to many diverse nations, Inuit and Métis people. We're grateful to have the opportunity to live, work, and gather on these territories. We acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, and the Williams Treaty, signed with multiple Mississauga and Chippewa bands. Since it's a virtual gathering, a singular land acknowledgement does not capture the richness of our distribution across many locations. There are few places on Earth that someone before us has not called home. Melissa, if you can move the slide. One more, thank you. So this is our Mary Seeman lecture, memorial lecture, in fact. I do want to acknowledge Dr. Mary Seeman, who made an extraordinary contribution to the Department of Psychiatry, a distinguished researcher in schizophrenia, and women in schizophrenia, as well as gender differences with schizophrenia, parenting with schizophrenia, many other aspects. And we're all saddened with the passing about a year ago. But with that, Dr. Michelle Craske will be presenting today. Michelle, if you can, Melissa, if you can move the slide, please. There will be an evaluation link to send to all the attendees after today's presentation. Your feedback is always appreciated. Next slide. The next Citywide Psychiatry Grand Rounds on May 30th, and hopefully we'll see you there. Next slide. That may be the last one. You can maybe take that down. Without further ado, our moderator for today, Dr. David Kreindler, will introduce our speaker, formally introduce the speaker. Thank you.
So I'd like to excuse me. I'd like to welcome everybody to the Dr. Mary Seeman lecture and to thank Dr. Craske for agreeing to present. Dr. Michelle Craske is the Distinguished Professor of Psychology and Professor of Psychiatry and Biobehavioral Sciences, as well as Kevin Love Fund Centennial Chair and Director of the Anxiety and Depression Research Center at the University of California, Los Angeles. She is also co-director of the UCLA Depression Grand Challenge. She has published extensively in the area of fear, anxiety, and depression, including over 630 peer-reviewed journal articles, as well as academic books and several self-help books and therapist guides, and is on the Web of Science most highly cited researcher list. She has been the recipient of extramural funding since 1993 for research projects pertaining to risk factors for anxiety and depression among children and adolescents, neural mediators of emotion regulation and behavioral treatments for anxiety disorders, fear extinction translational models for optimizing exposure therapy, novel behavioral therapies targeting reward sensitivity and anhedonia, and scalable treatment models for underserved populations. As part of the Depression Grand Challenge, she developed the STAND program for screening, tracking, and treating anxiety and depression. She is editor-in-chief for behavioral research and therapy. Dr. Craske received her BA honors from the University of Tasmania and her PhD from the University of British Columbia, and I'm very much looking forward to what should be a very good talk. Dr. Craske, the floor is all yours.
Thank you very much. Let me just share my screen. And there we go. Great. Thank you. I'm so pleased to be here and to present on the topic of reward processing as a treatment target for depression and anxiety. So my research focuses on two core motivational systems that guide our behaviors and our emotions. The defensive system that motivates avoidance of threats or punishments associated with negative emotional states such as fear and anxiety and guilt, and the appetitive system that motivates approach towards rewards and goals associated with positive emotional states, such as excitement, joy, and contentment. And for a long time, the emphasis, especially when considering anxiety, was upon the defensive motivational system and the extent to which its dysregulation or its excessiveness contributed to anxiety, and how treatments could best down-regulate this defensive system. But some time ago, we began to explore more of the appetitive system, primarily through our longitudinal investigations, such as this one. This was a study that we conducted with 16 to 17-year-olds who we followed for 10 years, and the goal of which was to examine different aspects of defensive and appetitive responding as predictors of the onset and trajectory of anxiety and depression over the next 10 years. And subsequently, another longitudinal study of 18 to 19-year-olds who we followed for 2.5 years with many of the same goals. And the findings from these longitudinal studies, as well as some other experimental studies, have really informed the first half of my talk today, which will focus on these three things: low positive affect as a risk factor and correlative depression and anxiety, the reward-related mechanisms that are associated with low positive affect, and reward-targeted intervention. So starting with the first point, low positive affect as a risk factor, a number of years ago, from one of our longitudinal studies, we found that not just high negative emotionality, which is not shown here, but low positive emotionality, often referred to as anhedonia, in 16 to 17-year-olds predicted the onset of not only depressive disorders, but also the two most common anxiety disorders over the next 6 years. And in the same group, we found that positive affect, positive emotion, buffered the effect of chronic interpersonal stress on the development of major depression and anxiety disorders over 8 to 10 years. And that controlling for other variables, interpersonal support, so the higher the scoring along the lower axis here, the higher the interpersonal support, the lower the probability of the development of depression or anxiety disorders over the next 2.5 years, which is relevant given the reciprocal relationships between positive affect and social support. In subsequent studies, we evaluated potential mechanistic pathways through which social support might operate, such as how does it influence the way in which negative experiences are reappraised. So here, for example, we had a group of individuals who were at risk for anxiety and depression because they were high on neuroticism. We asked them to identify their closest social support figure, and then ask them to reinterpret or reappraise a set of negative images, such as the ones shown on the left-hand side, either on their own, which was called solo, or with what their social support figure would say to them to help them to think differently. And found that when rated independently, first of all, the social support condition ended up with the better appraisals. So those who thought about what their social support figure would say ended up reappraising these kinds of negative scenes more effectively than if they were on their own. But also, after doing that, they were less likely to see an image as being bad if they had used a social support interpretation versus their own interpretation, and also had more positive affect if they used a social support interpretation than their own interpretation. So just a link between social support and the potential for it to change the way people think about negative events and its relationship with positive affect. Independent of social support, just coming directly back to positive affect, if we induce positive affect by having people remember positive autobiographical memories, and then asked them to interpret an ambiguous scenario, that positive induction of mood leads to a more positive interpretation than a negative induction of mood as a result of focusing on negative autobiographical memories. We've also looked at the positivity and negativity of life events. Now, most research to date has evaluated life events as either being positive or negative, when in fact they tend to be multifaceted. For example, the ending of a relationship as a life event can have the negative impact of having now to manage on one's own, but the positive impact of being relieved of conflict. And so we had a set of independent raters rate both the positivity and negativity of life events over the last 12 months from that group of 18 to 19-year-olds in our second longitudinal study. And then we evaluated the relationship between the positivity and negativity of life events and the onset of depression, anxiety. Now, just to complicate things a little bit further, when we evaluate depression and anxiety, we often prefer to use a dimensional model, and this one is called the tri-level model that we've developed. And in the tri-level model, it's a bifactor model. We have at the top a construct called general distress, which is primarily negative affect, and that is shared between the symptoms of anxiety and depression. And then we have two intermediary factors. One is called anhedonia misery. We changed the name to anhedonia apprehension. It's mostly low positive affect. And then the second intermediary factor is fear. And then we have a bunch of more narrow factors across the bottom. So now going back to the positivity and negativity of life events, what we find is that at the highest level of negativity of life events, so down at the bottom axis around 3.5, so very negative life events, we find that positivity of life events, so when positivity is high, as represented by this gray line, when positivity is high, the prediction of general distress is much lower than when positivity is low, which is the top line here. In other words, it appears that the positivity of life events buffers the negativity of life events in terms of how much it will lead to general distress, which is that shared negative affect between anxiety and depression. And then finally, taking the same sample of 18, 19-year-olds and following over 2.5 years, we find that this factor of anhedonia apprehension, which is one of the intermediary factors, predicts levels of interpersonal stress that are chronic, not episodic. So at the lower level of anhedonia, which means more positive affect, you see less chronic stress. At higher levels of anhedonia, which is lower positive affect, it predicts more chronic stress. So this is just a set of examples, and there are many other data points that I'm not presenting today, which show that there's a link between positive emotions and positive events having a protective influence upon the stresses that are experienced and upon depression and anxiety, sometimes in interaction with negative events. So what is the mechanism? How does this relate to the appetitive motivational system, or our responding to rewards? And here we're talking about both hedonic rewards, the hedonic pleasure and desire that comes innately with certain things like food, and also eudaimonic rewards of meaning and purpose, such as by helping another person. So how do those positive events and positive emotions relate to these kinds of rewards? Well, here my research has been informed by the Research Domain Criteria Initiative from the National Institutes of Mental Health, in which the appetitive motivational system is captured by the domain called positive valence systems. And the positive valence systems is in turn operationalized as a set of facets of reward responding, reward responsiveness, reward learning, reward valuation. And we've examined various features of these facets of reward in relation to positive affect and anhedonia, the lack of positive affect. Sometimes what we do is we present a set of positive images such as this, of happy little babies, of cute little animals, of beautiful nature scenes from my home country and my home state of Tasmania, or of kids having wonderful experiences and joyful times. And what we're looking at here is how do people respond to a positive rewarding stimulus? So that reward, initial response to reward. And what we found, as you might expect, there's nothing surprising here, with higher positive affect or lower anhedonia, same, reverse of each other. So higher positive affect, lower anhedonia. We see that people, when they're exposed to these kinds of images, they show higher positive valence. They rate the experience more positively. And this is regardless of how we measure positive affect and anhedonia. So this is the TEP scale. This is the positive and negative affect schedule, positive affect scale. This is the behavioral activation scale, reward drive. So in each case, the higher the score on the positive affect, the higher the rating of these kinds of positive images, a reliable effect. Nothing too surprising there. We've also looked at the anticipation phase of reward as well as the initial response to reward, which we were just looking at then. And to do both of these, we use what's called the monetary-centered delay task. This originally came from Brian Knutson's work. And in this particular task, we can measure both the anticipation and the consummation of reward. So participants are given a cue on each trial for how much reward they may gain or win and how much they may lose. See these listed across the bottom here. And then they're given a target in the middle, and they're instructed to respond as quickly as they can to that target in order to gain what they are being told they might win, or to avoid losing what they've been told they might lose. And then there's a feedback phase where they're told what they gained or what they lost. And we've done a number of studies with this task. In the first study, we sampled a set of 172 anxious or depressed primary care patients. And we looked at the various regions that seemed to become activated within the reward circuitry. And so typically that involves the ventral striatum, the putamen, the pallidum, and the orbital frontal cortex. And what we found was that as people were higher on anhedonia, so in this case, it's reverse scored. I know it's annoying, sorry. But here what it means is the higher the score, the higher the anhedonia, or the lower the positive affect, right? Then you're seeing lower activation in the orbital frontal cortex. As the affect becomes more positive, so the scores go down, you're seeing greater activation in the orbital frontal cortex in response to the win versus loss trials. Now, in our 18 to 19-year-old sample that we've followed for 2.5 years, we have found a very, very similar effect. But now we're talking about just the win versus no gain trials, which is honing in a little bit more on the reward-related processes rather than the win versus loss from the prior slide. And here, what we've done is we've included the regions of interest, the pallidum, putamen, ventral striatum, during the anticipatory phase of the MIT task, or loading on this factor of anticipation. And then we have the palladium, putamen, ventral striatum, and the orbital frontal cortex for the consumatory phase. And of all of these two phases, it's only the orbital frontal cortex that predicts anhedonia, which is here referenced as the intercept. So again, anhedonia is related to activation or underactivation, I should say, of the orbital frontal cortex during the consumatory phase of that task. Now, what is the orbital frontal cortex involved in? It's a regulatory region involved in the representation of reward value and regulation of reward responding. So we see that those individuals who have higher anhedonia seem to have less activation in this reward-related neural region. And moreover, the effect was specific to anhedonia relative to those other factors within our tri-level model, so general distress and fears. And it was also in the structural equation modeling specific to consumatory versus the anticipation phase. And remember, the consumatory phase was what we had found in our prior study with the anxious or depressed primary care patients as well. We have done other studies, and we also have a new study that's just been completed where we're looking at behaviors, physiology, and subjective experience in daily life using iPhones and Apple Watches as a predictor of the neural patterns at rest and in relation to reward tasks. So we're trying to see if we can identify patterns of behavior and experience in daily life that predict the anhedonic brain. So to that end, we've finalized data collection on 330 moderately to severely depressed individuals with varying levels of anhedonia, low, medium, or high, because we're trying to partial out what's due to depression versus what's connected specifically to anhedonia. And they go through 3 months of digital sensing with the iPhone and the Apple Watch, interspersed with bursts of EMA 5 times a day for 3 blocks of time, interspersed with frequent symptom batteries and almost weekly questionnaires. At the end of that 3 months, they go through a set of neurocognitive tasks, and we also look at various facial, linguistic, and focal features to see if we can predict resting state as well as reward task-based neural functioning to these kind of tasks. And this was part of a large consortium funded through the Wellcome Leap called MPsych. And our goal is, again, can we identify digital phenotypes, behaviors that will predict the anhedonic brain, I'm calling it that. And if we can, or even if we cannot, how can we predict based on that combined with EMA and standardized questionnaires and neurocognitive task performance and features during an interview? And that will hopefully help us then eventually say we don't need necessarily to do the neural measurement because we can get it all from these other indices if that pans out. Putting it together so far, anhedonia or low positive affect, it seems to be associated with certain deficits in reward functioning, whether it's at the neural level or the behavioral or subjective level. And our work, and certainly the work of many others, shows these deficits cover the gamut from the anticipation of reward to the consumption, to the amount of effort put into reward, the motivation and learning of reward. Which raises the question, how can positive emotions be raised in individuals who have this hyposensitivity to reward? And that's an important question because existing or standard pharmacological and psychological treatments have not been very reliable in raising positive emotions. They've been good at reducing negative emotions, but not necessarily raising positive emotions, even though that's what patients report that they have the greatest interest in having happen to them. Of course, there are some interesting newer findings happening with kappa opioid antagonists and ketamine, but in psychological terms, there's been very little. Even behavioral activation as a standalone treatment has not been reliably effective in raising positive emotions. So we went about the task of how do we develop a treatment that specifically and only targets all of these reward mechanisms, the anticipation of reward, the savoring of reward, which is the same as consumatory that I've referred to already, and the learning of reward. And because we want to have a very precise treatment that only targets these kind of mechanisms. So we selected, as you can see, there's quite a few different strategies. The top set are pretty much behavioral, the middle set are pretty much cognitive, and then we have mindfulness-based techniques in the lower level. And each one was chosen either because from experimental or preclinical data, there had been a connection with positive mood or reward processing, or because there was theoretical reason to do so. And so the treatment is 15 sessions. It begins with learning to label and discriminate positive emotions. It moves into the behavioral activation phase, but it's much more than behavioral activation. It's having people plan and engage in positive, rewarding activities, but the majority of the therapy in the session with the therapist is about savoring, how to go back and recall the memory for the experience in detail, savoring the emotions, the sensations, and the thoughts in as much detail as possible, especially given the evidence for patients with dysphoria to have deficits in memory for past events that were positive. And that takes 7 sessions. Well, I should say that we've done some experimental work around that savoring. This was a group of 96 individuals with high anhedonia, and we randomized them to either experiential focus on positive autobiographical memories, and this is the same thing I just described, that focus on reliving in the present moment, first person, the sensations, thoughts, and emotions that were occurring, versus an analytical recall, which is a narrative third person, versus a control, do as you would normally do. And we see that in those individuals who were trained to do the experiential focus, they had stronger positive affect than the analytical group. They had less negative affect than the analytical group, and they had less dampening of positive appraisals, meaning they were less likely to diminish the value of the positive experience in comparison to both the analytical and the control group. So that kind of going out, doing a behavioral activity, coming back, and 20 to 30 minutes in the therapeutic session, reliving and savoring that experience over and over and over again for 7 sessions. Then we do 3 sessions of cognitive training. Each of these exercises is designed to target a particular mechanism. So finding silver linings to offset the tendency to not attend to positive stimuli, taking ownership to offset the bias of attributing positive outcomes to external factors, and imagining the positive to offset the tendency to have very poor future-oriented positive mental imagery. And you can see what they're instructed to do below. And then the final 4 sessions, as I said, cultivating positivity drawn from mindfulness research, either intentions or actions that are designed to increase positive emotions. So in our first study, we took individuals who were clinically elevated on depression or anxiety and functionally impaired, and we randomized them to positive affect treatment, just as I described it, or to negative affect treatment. Now, negative affect treatment was literally 7 sessions of having people face the situations that they feared or avoided, then standard cognitive restructuring about overestimations of negative events and catastrophizing, and then finally 4 sessions of arousal regulation through breathing retraining. Each session we recorded positive and negative affect and depression and anxiety, and we conducted post and follow-up assessment. The positive affect treatment very much so increased positive emotions up to normative levels in the population, which had never been done before, and significantly more than negative affect treatment. Positive affect treatment also significantly reduced negative affect, not shown here, more so than negative affect treatment. It also significantly reduced depression and the stress scale of the depression, anxiety, and stress scale more than negative affect treatment, and suicidal ideation. So we conducted a second study. Now they're not only clinically elevated on depression or anxiety, but they're also severely low on positive affect in the lower 18th percentile. Again, randomized them, again, did the positive and negative affect and depression and anxiety measurement each week. And at weeks 0, 5, 10, and 15, we measured the reward targets, reward anticipation, reward savoring, and reward learning. Again, positive affect treatment did a better job at raising positive affect than negative affect treatment. Again, it was better at reducing depression and reducing stressful anxiety. And when we looked at the targets, each target was measured through multiple measures. The multivariate effect for anticipation of reward, which was comprised of self-report, heart rate to a version of the monetary incentive delay task anticipatory phase, as well as the expenditure of effort for rewards task, the multivariate effect showed greater change with positive affect treatment versus negative affect treatment, primarily driven by the self-report and by the heart rate, and that the overall multivariate change in the target correlated with changes in the clinical outcomes. Similarly, for savoring of reward, the multivariate effect showed stronger change in positive affect treatment versus negative affect treatment, driven primarily by self-report and a cognitive task. And again, the multivariate change correlated with changes in the outcomes. We did not get a significant multivariate effect for the learning of reward. So we're now doing we've just finished a third study, same comparison. The addition here is that we've included threat sensitivity targets to see whether there's specificity. Does positive affect treatment lead to more change on the reward targets than the threat targets? Does negative affect treatment lead to more change on the threat targets than the reward targets? We're still analyzing the data. I can say at this point, again, positive affect treatment is giving us better outcomes than negative affect treatment, but we haven't analyzed the targets. We've begun to look at moderators of effects to positive and negative affect treatment. The one thing that we've found thus far is that the higher the person's pre-treatment extroversion. Now, extroversion is a trait measure, again, largely made up of positive emotions, curiosity, in willingness to explore, positive affect. The higher they are on trait extroversion at pre-treatment, the more strongly they respond to positive affect treatment than negative affect treatment. So you get a much greater increase in positive emotions with positive affect treatment than you do with negative affect treatment. Whereas there's no difference between the two treatments if you're low on that trait extroversion. And that's interesting to me. That's a sign of a kind of a strength building model. If you start off high on trait extroversion, you're going to do better with positive affect treatment. But we have a long way to go. We've also been exploring using video or virtual reality to deliver the first half of positive affect treatment. So instead of asking people to go out and engage in daily life of activities that might be rewarding, we're actually bringing the rewarding activities to them through virtual reality, which is especially helpful when you're trying to do experimental control over what people are getting, and especially helpful for people who would not otherwise be able to access rewarding activities. Our first trial was an open trial. We got very good effects. Just doing this alone significantly reduced depression, anxiety, and anhedonia. We did a second, I should show you what the treatment looks like. People are immersed for 12 to 15 minutes in positive, rewarding virtual reality scenes. After doing the immersion, they then go through that recounting, that savoring of reward. So they sit back and they remember what was most positive and what was it as if it were happening again, first person, present tense. We do a transfer phase where we ask them to then recount a positive autobiographical memory, and then they do between session practice, and they do the whole thing over 13 sessions over 7 weeks. And just doing that in our first trial, shown here, was successful. We then did a second trial using a mobile virtual reality. So the first trial was using Oculus Rift, I believe, in the lab. The second trial was using a mobile version, which was a cheap set of headsets attached to the phone. We got effects, but there was such a high dropout rate because it just wasn't very good quality at the time. But what was interesting in that mobile version, so those assigned to the mobile version, we looked at sentiment analysis of their recounting of the virtual reality scenes. So sentiment analysis, we used BERT sentiment, which is a machine learning framework for natural language processing of what they wrote down as they recalled the virtual reality scenes. And you can see that the sentiment became more positive. This is an index of positive minus negative. So the sentiment as they recalled the virtual reality scenes became more positive over time. As they recalled their autobiographical memory scenes, they didn't become more positive over time because they were at such a high level to start with. But what was most interesting is the increases in positive sentiment for the virtual reality scenes actually predicted reduction in symptoms of depression and symptoms of anxiety from pre to mid to post training. So this is somewhat of an index that getting access to that positive emotion through the sentiment analysis of the virtual reality recall was a good predictor of outcome. And we've just completed a trial now where we've compared the virtual reality reward training using the proper Oculus Quest equipment in the lab, not the mobile version. And we've compared it to a stringent control, which is virtual reality memory training. So instead of getting positive scenes, they get neutral scenes. So it's quite a stringent control. And we are finding an effect of that virtual reality reward training leading to a greater reduction in anhedonia by the period of follow-up compared to the memory training. We had to co-vary pre because there are differences at pre. And also that the virtual reality reward training in the dotted line, this is ratings of positive affect, changes in positive affect from before the virtual reality scene to after the virtual reality scene, the first half of treatment and the second half of treatment. And you see that by the second half of treatment, the virtual reality reward training is leading to a greater increase from before to after each scene compared to the memory training. So I think there's something here. I think there is something that can be of value for the virtual reality, either as a standalone or as an add-on to therapist-delivered therapy. Okay. What's the relevance of this to exposure therapy for fears and anxiety? So I want to talk in the last part now of my presentation about, let's remember, low positive affect is a risk factor and correlate not just of depression, but also of anxiety. We've already talked about the fact that there are reward-related mechanisms that seem to be associated with low positive affect. What I want to introduce to you is the possibility that low positive affect may actually be an impediment to extinction and also hence to exposure therapy. And what are those reward-related mechanisms in the context of extinction and exposure therapy? So we've already shown over a number of years that higher positive valence has an effect on extinction. So if you rate a conditional stimulus more positively at the end of extinction, you're going to have better long-term extinction. If you have positive affect induction before you go through extinction, you have stronger long-term extinction. If you are an individual with low positive affect, you'll show more reacquisition, so poorer long-term extinction. And we've reviewed all of this. Now, going back, so that's suggesting that at a behavioral or psychophysiological, peripheral psychophysiological level, there's some connection between high positive affect, better long-term extinction. Low positive affect, worse extinction. Going back to our neural studies, this was the 18 to 19-year-old age group. We put them in the scanner and we took them through standard Pavlovian fear acquisition, fear extinction, and fear extinction recall. And then we related their neural response to the tri-level factor, general distress, anhedonia, and fears. And the biggest effect we found was with anhedonia and with extinction. So what we're looking at here is how people are responding to what's called the CS plus, which is the dark line. Now, this is during extinction. So they're in the phase of the experiment where this stimulus that previously had been paired with the shock is no longer being paired with shock, compared to the CS minus, the dotted line, which was never paired with shock. This is the last stage of extinction. So they've had many trials showing that this CS plus, the dark line, is no longer a predictor of shock. And yet, as anhedonia increases, so along the x-axis, the higher the score, the more anhedonia, you see that they're reacting as strong, they're still reacting more strongly to the CS plus than they are to the CS minus, as if the CS plus is still threat predictive across multiple regions, the DNST, the amygdala, the insula, the dorsal anterior cingulate cortex. Whereas those with lower anhedonia lose that reactivity to the CS plus. So anhedonia, or low positive affect, seems to be weakening extinction. Higher positive affect, strengthening extinction. We've replicated or extended that analysis by using structural equation modeling. So it's the same sample of people, but now we're throwing everything into one model. We have all of those regions and more that I just listed on the prior slide. We have them linked up with acquisition, extinction, extinction recall. So we're using latent constructs for each of these phases based on their connection with each of these regions of the brain, the threat circuitry. And then we're testing whether these regions, these latent constructs of neural reactivity, correlate with our symptoms of anhedonia, general distress, or fears. And again, it's only extinction and it only relates to anhedonia. So poorer extinction relating to higher anhedonia. And it's specific to anhedonia versus general distress and fears, and it's specific to extinction versus acquisition or extinction recall, which is another topic another time. Why it didn't relate to fears, we don't know. The extinction is relating to anhedonia. And in another set of analyses of the same sample, we explored whole brain multivoxel pattern analysis to decode neural patterns associated with those same symptom dimensions. And the symptom that the decoder was able to decode was symptoms of anhedonia. And in a cross-validation test, the decoder that was developed at the UCLA site was then tested in the sample recruited at a Northwestern site. And again, the decoder predicted anhedonia even after covarying fears and general distress. So it appears as if low positive affect is somehow very uniquely associated with extinction and in the direction suggesting of weaker extinction, higher anhedonia, weaker extinction, or another way of saying it, lower positive affect, weaker extinction. So what is going on there? What's happening with the reward-related mechanisms in exposure therapy? Well, my colleagues such as Brown-Vervliet, Raphael Kalish, and others have said prediction error during extinction, so the point at which the expected unconditional stimulus does not occur, is a better than expected outcome that generates positive hedonic value, rewarding value. The bad thing did not happen. That's good. Silencing of the dopaminergic neurons in the ventral tegmental area, the cited prediction error at US emission, prevents extinction. So if you interfere with that process, you block extinction. And remember, anhedonia is associated with reward hyposensitivity, meaning less hedonic value, and dopaminergic dysregulation. Therefore, those with low positive affect may show impaired prediction error learning throughout extinction and exposure therapy. I am conscious of time, so I may have to skip a couple of slides and get to this. So we have compared exposure therapy, which is based on the prediction error model. We call that the inhibitory retrieval model of exposure therapy, to exposure therapy based on the traditional habituation model, where you just simply reduce fear responding by having people repeatedly face a feared situation over and over and over again. The inhibitory retrieval model is a very different approach, which is all about how do you maximize prediction error. And what we've found is that the inhibitory retrieval model, when we do a randomized controlled trial, results in significantly steeper reductions in self-reported anxiety than the habituation model, results in significantly greater reductions in self-reported distress during a behavioral approach task than the habituation model, and results in significantly greater number of individuals who achieve clinically significant change at post-treatment with trends at follow-up than the habituation model. Prediction error, as I said, is critical to this inhibitory model. We have people rate before you go through exposure. How likely is it that you think that bad thing's going to happen to you? 75%. After exposure therapy, did it happen? No. If you had to repeat the exposure practice again, how likely is it that would occur this time? Only 25%. We see that as expectancy change from 75 to 25. And that expectancy change is a learning from prediction error. What they expected to happen did not occur. And we found that that expectancy change predicts the reduction in anxiety at post-treatment and at follow-up, even when we do a computational modeling of learning rate. It predicts reduction of anxiety from pre to post and pre to follow-up, whereas fear change, just the reduction of fear, does not predict outcomes. So the prediction error mechanism is relevant. So coming back to our question, do individuals with lower positive affect show impaired prediction error throughout extinction and exposure therapy? Our findings so far are it may. And this is based on the inhibitory retrieval exposure. Complicated slide, but if you look along the bottom axis here, this is the point at which they're saying, I really think that bad thing's going to happen to me. And the y-axis is saying, after they've gone through the exposure, if they had to do it again, how high do they think their expectancy would be? So at pre-exposure, where you want the highest expectancy going into the exposure, if the positive affect is high, which is the light line, their post-exposure expectancy is quite low. But if their positive affect is high, their post-exposure expectancy remains high. In other words, they don't have as much expectancy change. And this is all within session. within person. So it's occasions of positive affect. So on occasions when somebody goes into an exposure trial feeling positive, they're more likely to have an expectancy change. They're more likely to learn from the prediction error at the point at which it's most essential. And that's relevant because, as I showed before, expectancy change predicts outcome. And so that means that we may well do more about how do we help people to raise their positive affect as they go into exposure therapy. So I'm conscious that I'm probably running out of time. Is that right, David? Yes. So I will say at this point, thank you very much, and I will open it up to questions.
Thank you very much, Dr. Craske, for a fascinating talk with a lot of things to think about. I'm wondering if perhaps I could just lead off the questions here with thinking about a patient of my own who I've been seeing for about 1.5 years now with chronic depression and no benefit whatsoever to a whole bunch of different kinds of interventions, including therapy. This poor kid comes from a family where academics is prioritized. He puts a lot of pressure on himself about getting homework done. He seems to be spending every waking moment that he's not actually in school grinding through homework and having an absolutely miserable time, including immediately before he goes off to therapy. And I'm wondering if on basis of this talk, I now have solid evidence-based evidence with which to tell parents, give this kid a break, let him just take some downtime for an hour before going talk to his therapist and seeing whether or not they should expect to see better outcomes from therapy.
I mean, clinically, that's what we would always be doing anyway, right? When you see somebody who's spending all of their time struggling at an aversive task, you probably would want to say, let's have a break from that. But what this work is saying, you need to do more than have a break. You need to, and the way we present it to patients who come to us with so much adversity in their lives, and here we are saying, hey, focus on the positive. And they're saying, but there's all this stuff happening in my life which is so negative. How can I ignore it? Our response is, we want you to build capacity. We want to train you to be able to think about, imagine, anticipate, and experience positive moments so that you're better able to cope with the negative experiences in life. So we sort of present it as a way of making the rest of life more manageable. And so definitely with that kid, I would be emphasizing finding ways to build up blocks of time to experience, look forward to think about, plan for, and then savor positive experiences for sure.
We have a number of questions in the Q&A. One question was whether you could comment on the impact of the use of street drugs of abuse in individuals in situations like this. How would you see that as affecting the impact of, how would you see this?
Yeah, very interesting question. Unfortunately, in our studies, like in a lot of studies, we exclude patients who are abusing substances. And of course, even in our neuroimaging studies, we exclude patients who are abusing substances because of the complicated relationship between substances and the reward centers of the brain and the craving versus liking of reward. I think what I would be, I'm not the expert in this, but I think what I would probably be doing clinically is validating that the substances may be providing that sense of reward in some ways, but that the consequences of it validate the need to justify finding other ways of obtaining reward, and maybe perhaps build up the capacity to experience reward in different ways. Perhaps that might even lessen the desire for the drugs, but unfortunately, I'm really not an expert in that area.
There's a question about whether or not encouraging clients to focus on positive memories in the past could potentially run the risk of causing more current frustration for them because of the comparison between their past and present states.
It does. So clinically, that often happens where we start off with, so we're going to think about a positive past experience, and then the client's initial response might become, well, why didn't I have more of those positive experiences? What did I do wrong? Or I'm such a failure that I didn't try to expand upon that one time. You know, there are lots of ways in which you can lead into the positive. We identify that immediately. We help them recognize how they're now shifting attention away from the positive. We validate that that is the very process we're trying to target, that tendency to diminish the positive, even though it's in the context of lots of other negative things. They're still diminishing the positive, and we're trying to build the capacity for that positive. So we validate and bring back to the positive.
Thank you. There was a question about whether you could comment on the implications of the studies you presented on the current well-being movement, where people try to improve well-being by movement that seems to be associated with a paradoxical decrease in well-being among youth.
Oh, interesting. I'm not as familiar with that. I don't know if the well-being movement is as structured and focused as this treatment. I mean, I think if it's more about just try to be happy as a well-being movement. So I'm feeling rather unable to answer that question because I just don't know what the well-being movement is.
We have 2 minutes left here. Is there a role of building the concept of self-worth in addressing some of these issues?
You know, one part, yes, I think there is a value of self-worth. In the cognitive phase, one of our skills, I call it taking ownership. It's actually helping the client to say, this positive, you know, somewhat positive event happened in my life. Their typical response is to say, it had nothing to do with me, or I did nothing to contribute to it. And we spend a lot of time in that session focusing on helping them to recognize what they did that contributed in some way, any way, to that event occurring, and taking ownership. And the taking ownership is a way of improving self-worth. And in the cultivating positivity, we do a lot on generosity and having them practice helping others as a way of improving their own sense of worth. I think that's a very important construct.
So with apologies to all the excellent questions that we haven't had a chance to get to because of lack of time here, I'd like to thank you very much for a fascinating talk and for engaging with the questions as well. That concludes the Mary Seeman lecture, and I will turn it back to Dr. Rasassingham.
Thank you, David, and Dr. Craske for this wonderful presentation and engaging talk. Thank you, and I really appreciate it, as well as the panel discussion was amazing. Thank you, everyone, for joining our Mary Seeman lecture. For those of the Future of Psychotherapy Conference, you have a link in your emails to the 2 different workshops we have for the afternoon. There is a break, so you will have a little bit of a break, a 20-25-minute break, and then please join the link to the which workshop that you would like to go to. So it is in your email. If you have any problems, you can email Anne-Marie Raswan and she can help you. So thank you, everyone, for joining today. Take care. Bye.
Thank you.